Americans, including the patients I have served over my lifetime, are living longer and better quality lives because of the products that the companies have created. Unfortunately, that's not true for all. Although Medicare Part D has made a substantial improvement, people of color, the elderly, disabled, and the poor continue to not be able to afford medications that they need to keep them healthy, despite some of the free and discount programs. I know that medication costs are not the only cause of increasing healthcare spending. I'm also not against profits, and most definitely I support the research and development, which has resulted in better lives for all of us. But I do not discount the AARP report either, as it tells a true story of people across this country who cannot afford to take all of their medications every day as prescribed. So I don't think we should make light of that report at all. I'll start with Ms. Kramer on my first question. AARP plays a critical role in advocating for its membership for seniors and really for everyone on health care, retirement security, and things that all of us care about. And I would assume that the membership dues alone don't support these activities. Is it safe to say that the royalties that we've heard so much about this morning are used to make important services available to your members and to fund advocacy efforts on issues that even some of those companies that are paying those royalties may not agree with AARP on?
Yes, that is safe to say. We often have disagreements with the providers, but the royalties do support AARP, our education, our advocacy, our member engagement, not only in Washington, D.C., but as you know, with the 53 state offices in the territories and the states.
So we thank you, and we thank you for the support that AARP has given to the Virgin Islands. Mr. Smith and Professor Vernon, this is on pricing, so I can understand this better. At the point at which generics come on the market, has the brand name producer generally recouped their cost to research and develop those products? And if so, why then do the costs continue to go up after that point, especially in excess of what the inflation is? And I ask that because when you see the new technologies come on the market, they're usually really expensive. And after a few years, their prices go down, but it's the opposite for pharmaceuticals. So can you explain that for me?
Professor, your mic's not on. You have to.
Sorry about that.
That's all right.
I would also add that we have very intense generic competition at patent expiration for very large, successful products. The price of generics is driven very rapidly down to the marginal manufacturing cost of pharmaceuticals. We have the most competitive, lowest price, highest utilization rate of generics in the world, very successful as a result largely of the Waxman-Hatch Act. I would also say that there is some uncertainty whether pharmaceutical prices have indeed been rising as fast as has been purported in this hearing. And also, I would add one more point, and that is that the suggestion that the firms are raising prices in anticipation of health care reform is not at all clear. Certainly, the most comparable recent legislation to the current legislation was the Clinton Health Security Act, where we saw firms pledging publicly that got them in trouble with the FTC to restrain drug prices. There are other factors like compressed product lifecycle cash flows as a result of patent challenges, intensified generic competition that could be driving what we're observing in the pricing of pharmaceuticals.
But isn't the same kind
as
of
well as the mix of
competition-
biologics and pharmaceuticals, a shift towards more costly to develop biologics, which have higher prices, and fewer pharmaceuticals.
But don't, in the, well, it may be 12 years, we hope, but wouldn't you expect to get back what you've put into R&D and begin to make a profit in that period of time? That's what we're assuming. And I just don't understand why the prices keep going up when a product's been on the market for years.
Well, yes,
the technology has the same kind of competition, but their prices go down.
Well, I think there are a lot of dynamic factors, and certainly the market is very different now. As I said, we have much more intensive generic competition. We have a higher rate of patent challenges. We have a lower productivity with respect to pharmaceuticals, and we're seeing more biologics on the market, which have a higher financial cost of capital and higher manufacturing costs. So we're seeing that mix shift between pharmaceuticals and biologics, which is contributing to.
Let me try to get another question into Ms. Stahl and Dr. Schandelmeyer. We all acknowledge that our health status in this country would not be where it is were it not for the investment in research and development that the pharmaceutical companies make, although it would be a lot higher and better if all of us were able to participate and had access to those drugs. Do you believe that there has to be a trade-off between research and development and lowering the cost to consumers? Because research and development always is what comes up when you talk about lowering costs.
I believe there is a trade-off we're making already, but we're not doing it very consciously. We're doing it more implicitly rather than explicitly. In America, we may generate much of the R&D for the world that finds new medicines, but we probably have a higher percentage of our population as a developed country who don't have access to medications than any other developed country. And so that's why our health status overall is down around 20th in the world instead of at the top of that list. So we are making that trade-off already, and some people are paying the price. Others derive the benefit of the wonderful medicines that are discovered.
But
we're going to have to stop, only because I can't allow the others. All right.
Thank you.
Thank you. The gentleman from Maryland, Mr. Sarbanes.
Thank you. Move over here. Thank you, Mr. Chairman, and I appreciate you all coming back or staying while we came back. Dr. Schandelmeyer, is the cost of R&D something that's accounted for before the profit numbers that we hear about, or is it something that happens with the profits?
As I understand the way drug companies keep their books and the profits they report to Wall Street, R&D has already been costed out at that point.
Right. So we're looking at profits of $51 billion in 2008, a 19% return on revenue, and over the last, or since 2005, $180 billion in profits. And this is after the R&D. So that makes this kind of R&D justification for where the pricing is less compelling to me, if I'm understanding sort of how the books are kept on that. I have to say, Mr. Smith, I know you can't comment on the motives, but I have no doubt that the pharmaceutical companies are running up the price in anticipation of health reform based on past experience with them doing that. We see it also happening with the health insurance industry. There's evidence that the premiums for next year's renewals have been sky high with the recent notices that have gone out. The disappointing thing with the, well, I guess it cuts both ways. I'm disappointed maybe that the health insurance industry didn't make a deal the way pharma did, but I'm disappointed that pharma, having made a deal, appears to be price gouging in anticipation of what's coming, so they can establish a new baseline. My question was, the deal as it's referred to, I guess, was about $80 billion. Is that represented by the 50% discount that is expected to be offered to people in the donut hole, or does that account for some other things as well?
Congressman, as I mentioned earlier, I didn't come prepared to testify about the deal, but at a broad level, the industry's contribution toward the cost of health reform would include the 50% discounts in the coverage gap. As you know, both bills, both House and what we see in the Senate, include very substantial increases in the Medicaid rebate, very substantial extensions of the Medicaid rebate across to a much broader population than it applies to today. Beyond the currently uninsured population will become eligible for Medicaid. As you know, the Senate bill includes some other fees, and as you know, both bills include provisions to create a pathway for follow-on biologics that also come with a pretty sizable government score.
Well, I would hope that the contribution that pharma is willing to make would increase in relationship with the change in the baseline on the drug pricing that's appearing to occur right now. In other words, if at the time the deal was made, the pricing was here, and that meant that a 50% contribution to the cost in the donut hole at that pricing represented this amount of money, then if the pricing is going up substantially, then the amount needed to cover a 50% discount would also go up. And beyond that, the amount needed to get you back to the anticipated discount for the consumer would even be more. So I just hope that pharma is ready to stick with the deal it made in terms of the effect or the benefit it would have on the consumer in relationship to the increase in the baseline that seems to be occurring as a result of, again, what I view as a kind of price gouging scheme in these last few weeks and months. And with that, I'll yield back.
Thank you. Let me thank all of you for coming today. I know this is not an easy issue. The way it works is members can still submit written questions through the clerk, and I think the clerk's supposed to get back to you within 10 days or so. So we still may get additional written questions, and I know that a number of you said you were going to respond in writing to some of the questions that were asked by the members as well. But in any case, we do appreciate you coming.
Mr. Chairman,
yes.
Can I ask unanimous consent? We are up against the clock here at the end of the year, and to the extent possible, could we have these written responses within 5 days so we would have an opportunity to evaluate those before we get into this ping-pong match with the Senate with whatever they're going to do at the end of the year?
I mean, the way the rules are, we usually have 10 days for members to submit the questions, and then we send them to the witnesses. And I mean, I don't think 5 days is enough time. I would ask that you get back to us, fairly quickly, but I don't want to put a date on it because I think that, it depends how complex they are. But please get back to us, as quickly as you can once you get the questions.
But, Mr. Chairman, further inquiry, I think you'd acknowledge it's unlikely that this health care bill is going to go to a conference.
Well, I think it'll probably go to the if it's passed by the Senate by the holidays, we'd probably go to conference in January. It all depends on when the Senate passes it. But the intention is to go to conference. I don't know how we could avoid that, given there are probably going to be major differences between the two.
The way we would avoid it is your speaker would say we just simply have to accept what the Senate does, and we will acquiesce to the Senate bill before the end of the year. I mean,
Dr. Burgess, I can't predict that. Right now, that's not what everyone is saying. They're saying that there will be a conference, and I think it's likely that there will be.
Well, I'm depending upon you as my subcommittee chairman to advocate that there be a conference and it be a real conference.
You do not have to worry about my advocating for a conference. I will advocate for a conference, I assure you.
Well, the same way you advocated for a subcommittee markup. I'll yield back.
All right. I guess we're done. So without objection, the subcommittee is adjourned. Thank you.
Yep. I imagine we'll see each other again. Thank you. Thank you. Oh, I Stephen.
I would like to say, and I was hoping to have the chance to say this, but I do hold you in the highest regard with respect to your research and everything. So I enjoy reading your